Good evening, everyone. I'm Dr. Sanjay Kumar Edla. I'm a uro-oncologist based out of Hyderabad. Today, for the So Go Back to Basics, we've got quite an interesting one. We just wanted to have it as a basic one, but wanted to touch upon something that we don't tend to look at normally, which is the non-surgical management of small enhancing renal masses. And what hopefully we'll do at the end of this next 60 minutes is that these options are valid options, and there is quite a good scientific basis for this, and the outcomes are also acceptable. We'll see whether they are as good as partial nephrectomy, but they are acceptable to our understanding. And I've requested Professor Vedang Murthy from TMH to lead on this one, and I'm going to hand you over to him. He will conduct the next 60 minutes. And if there are any queries or anything, if you put them up in the chat, I will ask them. Or if there are any questions from my side, I will ask them. Professor Vedang he heads the Uro-Oncology DMG at Tata Memorial Hospital, and majority of you who are logging in would know about him. So, Vedang, good evening, and thank you very much. If you can take over.
Thank you, Sanjay. Good evening, all of you. Let's crack on. So the program today is as follows. We'll have three short talks. One about what to do with a small mass when we don't do anything. Second is what to do with it when we have an opportunity to use heat or cold, or anything else that our radiologist is going to tell us. And if nothing is right or nothing works, what can we do with radiation, and can we do something for these? And after that, we have a very interesting session of that will be conducted by my senior resident, Dr. Sheetal Kashid. It has our fellow panelists are going to talk about, all residents and fellows are going to talk about 5 or 6 cases that we may see any day in our clinics, in OPDs, in different points of time. And the criteria is they are not, either they don't want surgery or they can't have it. So the non-surgical options will be discussed, and how to go about it. So let's crack on. Rajesh, Dr. Rajesh Kumar Reddy would talk about how we do surveillance.
Rajesh, you can start off.
Please start, Rajesh. We can see your screen. You are muted, man.
Yeah, sorry. I'm sharing the screen.
We could see your screen before.
Yeah. Good evening, everyone. I'm Dr. Rajesh Kumar Reddy from Asian Institute of Nephrology and Urology. I'm going to discuss a few the practical aspects on active surveillance in small renal mass. So what is the definition of small renal mass? It is not as simple as renal mass size less than 4 centimeters. The strict definition of small renal mass is the incidentally detected, localized, contrast-enhancing renal cortical solid tumor, which is less than or equal to 4 centimeters in maximum tumor diameter on cross-sectional imaging. This is the strict definition of small renal mass for all practical purposes. It is not applicable for cystic lesions or fat-containing lesions like angiomyolipoma or any invasive tumors. There are various treatment options available, and partial nephrectomy is currently gold standard method. And I'm going to discuss the active surveillance, which is being emerged as a safe alternative to the surgical intervention. So whenever there is an alternative alternative intervention, there are WHO questions will crop up. So I'm going to answer these questions. The first one, what is active surveillance? So it is defined as actively monitoring the tumor size as well as character by serial imaging and offering the delayed curative treatment in case of disease progression. This involves strict selection criteria, stringent clinical follow-up, scheduled imaging, and whenever there is a progression, suitable intervention to be performed. It is not synonymous with observation or watchful waiting, where there is no strict selection criteria, no stringent protocols. Intervention is considered only whenever there is a symptomatic progression. So why active surveillance for small renal mass? What's the rationale? The most important thing is biological heterogeneity of small renal mass. Historically, the incidence of the substantial proportion of the small renal masses are either benign or indolent. Here we can see the benign lesions are 20%, and indolent lesions, even though they are cancerous, is 50 to 60% of the small renal masses. So aggressive phenotypes only 20 to 25%. So one size fits for all strategy is not the welcome thing for small renal mass, considering the biological heterogeneity. Coming to the slow growth kinetics and low metastatic potential. Historically, the median growth rate of small renal mass is 0.28 centimeters per year. But the studies, as per the recent data, it is around 1 millimeter per year. So, and the risk of metastasis is just 1 to 3%. When compared with the large renal masses, which has got rapid growth, 4 to 8 millimeters per year, and high risk of metastasis, that is 46%. And small renal masses, when compared with the large renal masses, has got very the good 5-year cancer-specific survival, that is around 95 to 100%. And interestingly, the risk of death is due to other causes is higher rather than because of the cancer-specific mortality. And another interesting epidemiological observation was made. In spite of early detection and treatment of small renal masses, the RCC mortality has been stable. This is called epidemiological paradox, that is called treatment disconnect. There is something wrong with the gold standard treatment, maybe overkill. So we cannot deny the fact that intervention, especially the surgical intervention, is associated with the potential complications, and there are few cost issues which can be easily avoided, at least for selected patients of small renal masses where active surveillance can be considered. So who are eligible for active surveillance? So there is no level 1 evidence for active surveillance in renal masses. So hence the selection criteria are very strict. As per the standard guidelines, ASCO, AUA, EAU, and NCCN, all the guidelines mentioned the recommended the active surveillance only for the patients with significant comorbidities or limited life expectancies. AUA and NCCN guidelines provided size criteria of 2 centimeters. So when oncological benefit of active surveillance overweigh the risk of intervention, active surveillance can be considered safely. What are the contraindications for active surveillance? Benign renal masses, reliably diagnosed by imaging or biopsy, like renal cyst or angiomyolipoma of the kidney. We really don't need to do a stringent follow-up and repeated imaging. So we can just keep the patient under observation rather than a strict actively monitoring the renal mass. And second thing, renal mass with high risk of invasion based on the imaging or biopsy, even though size is less than 4 centimeters, better to go ahead with intervention rather than active surveillance. When patient is unwilling or patient is non-compliant for active surveillance, better to consider intervention rather than active surveillance. So how to follow up these patients? After cross-sectional imaging, once patient is selected for active surveillance, stringent protocol is required, especially the imaging, the contrast enhanced cross-sectional imaging. It is mentioned 3 to 6 months, every 3 months CT scan is maybe a overkill, at least once in 6 months for first couple of years, and that is followed by annually for 5 years. After 5 years, if the tumor is stable in size, better to discontinue active surveillance, or you can just reduce the follow-up visits. If the tumor is slowly growing, continue imaging once in a year. If there is a progression of the disease, the definition of the progression I'm going to discuss later. If there is a progression of the disease, better to consider intervention as suitable for the patient. So when to discontinue active surveillance? If the tumor size crosses 4 centimeters, better to go for intervention. If the linear growth rate, that is the difference in the maximal tumor diameter in 1 year, if that is more than 0.5 centimeter per year, better to go for intervention. If the tumor doubling time is less than 12 months, development of the symptoms, progression to metastatic disease, and patient's choice to undergo intervention, these are the criteria to discontinue active surveillance. The last one is most important thing. The majority of the patients, even though there is no progression of the disease, they have done a crossover. They have opted for intervention in the recent prospective trials. Here is one of our cases. So one patient presented with incidentally diagnosed enhanced left renal mass. Here we can see the central necrosis. It's a biopsy-proven oncocytoma. The size and character of the tumor did not change in 4 years. It was first diagnosed in 2019. Here we can see the picture. Here the city of the recent most in 2023 October. So if there is no change in the size, no change in the character of the disease, better to keep the patient under active surveillance only. So what is the role of renal mass biopsy? We all know that there is a lot of biological heterogeneity in the small renal mass. So with the advent of the refinement of the biopsy techniques as well as the immunohistochemistry techniques, the overall diagnostic rate has improved to 92% as per the current literature. And here we can see in this biopsy proven cohort, the subtype information can be obtained by the biopsy, where we can see the clear cell tumor is growing very fast rather than when compared with the other subtypes. But there are a few problems with the biopsy, especially the problems with non-diagnostic biopsies. There is nothing called benign biopsy or negative biopsy. If there is a positive for malignancy, that is positive. If it's a negative for malignancy, that may be positive, that may be malignant as well as may be benign. We don't know. So the problem with the non-diagnostic biopsies is still high, and it is less accurate for the grade confirmation, which is an important prognostic factor. What are the outcomes of patients undergoing active surveillance? The first question, are we losing the window of opportunity to provide the nephron sparing surgery? So as per the recent prospective data, there are no significant differences has been observed between primary intervention versus delayed intervention with respect to minimally invasive treatment or nephron sparing intervention. But theoretically, there is definitely a risk of losing the window of opportunity. And risk of progression to metastasis, rendering the patients from curable to incurable. So as per the retrospective data, in the active surveillance cohort, the risk of progression to metastasis was as high as 5.7%. However, with the strict selection criteria, strict follow-up protocols, and refinements in the biopsy and imaging techniques, the recent prospective studies, the risk of progression to metastasis is as low as less than 1%. I would like to make a special mention about the DIS-SRM registry, that is a delayed intervention and surveillance for small renal masses. This is a multi-institutional prospective cohort study, which is currently a world's largest prospective program, which is designed to report the outcomes of active surveillance versus intervention for newly diagnosed small renal mass. It was started initially in Johns Hopkins University and extended to other centers too. As per the study, the recently 10 years update of the DIS-SRM registry was presented in AUA. So total 785 patients have been enrolled since 2009. And among them, 348 patients chose intervention and 437 patients chose active surveillance. From active surveillance cohort, 67 patients underwent delayed intervention. This includes patients' choice too. There need not be progression for all cases. When the patient wants to the crossover to intervention group, they can do. And the median follow-up time for the entire registry was 3.3 years. However, more than 1/3 of the patients have already crossed 5 years of follow-up. Here we can see the cancer-specific survival is non-inferior in active surveillance cohort when compared with the intervention. However, in overall survival, there is a lot of difference. The active surveillance group, the overall survival is very less when compared with the intervention. This is by and large because of the strict selection criteria. So the patients who have the multiple comorbidities or limited life expectancy, they have been selected for active surveillance. They have been chosen for active surveillance. That is very important. So probably that is the reason for the difference in the overall survival. However, the cancer-specific mortality is non-inferior. So having said that, the current evidence of active surveillance for small renal mass is based on the observational data, and it is subjected to many biases, especially if the tumor is benign looking or indolent masses. Usually it will be selected for active surveillance rather than the intervention. And tumors which are aggressive looking on imaging or biopsy will be selected for intervention. And another the caveat is the tumors do not always follow the rules. So, for example, this is the case of Bosniak 3 cyst, the left renal cyst has been under observation elsewhere since 8 years. Patient never had symptoms. Patient lost follow-up after 5 years also. And recently, patient presented with the back pain. And imaging shows there is a renal mass here, and we can see the metastatic lesions in the vertebra. The biopsy of the vertebral mets, the clear cell RCC. So definitely we lost the window of opportunity. So the most important thing is there is the unmet need of diagnosing the wolf with sheep clothing. So in future it may be brighter with a better molecular markers, genomics or radiomics. We may be able to differentiate the aggressive phenotypes and select for intervention rather than active surveillance. So in conclusion, small renal masses are biologically heterogeneous. A substantial proportion of the patients, 75 to 80% of the patients with small renal mass, the 80% of the small renal masses are benign or indolent, and hence active surveillance is potential option. However, there are a lot of uncertainties do exist in assessing the malignant potential of the tumor. So careful risk-benefit analysis and shared decision-making are essential components of active surveillance. There is no level 1 evidence for active surveillance, and still to date, partial nephrectomy is currently gold standard for small renal masses, and active surveillance may be considered as safe alternative for highly selected patients. Thank you.
Thank you, Rajesh. There is a
I just
question.
want here from Dr. Meenakshi Kamboj saying that is age a criteria for active surveillance? I would probably just answer saying that the expected lifespan is much more important rather than the definitive number of the age. So if somebody has got a life expectancy definitely of less than 5 years, I would push more down the line of watchful wait, 5 to 10 years, where you would say that active surveillance would be an option. Thank you. Vedant, do you want to go ahead? Thank you very much, Rajesh.
Thanks, Rajesh. Let's next ask Dr. Antariksh, who's a fellow in interventional radiology, to speak about his trade. While doing that, I think I found it very interesting that registry data, Rajesh, that you showed, when there was intervention, the outcomes were about 20% better than surveillance. And I assume surveillance was done because patients couldn't undergo intervention, largely a partial nephrectomy. Is that about right?
Yes, sir.
And that is why these next two talks are so important to make our friends and the uro-oncologists and urologists realize that there is something more available, more than active surveillance. So it is, and that is why these two next talks are very important.
So shall I start with the talk?
Yes, please.
I hope my screen is visible and I'm audible. Okay. Okay. So thermal ablation in small renal masses, why, when, and how? We've just seen that the incidence of RCC is on the rise, and this parallels the increased use of cross-sectional imaging, which enables, quicker detection of small enhancing renal masses, which we have seen are defined as incidentally detected, contrast enhancing solid lesions less than 4 centimeter in size. And these are typically consistent with a clinical stage T1A. Among the surgically treated small renal masses, data shows that about 80% are malignant and the remaining 20% are benign, typically including oncocytomas or even fat-poor angiomyolipomas, that is, angiomyolipomas that do not contain any fat within them. And these can be a mimic of RCC on cross-sectional imaging alone. Although nephron-sparing surgery does remain the gold standard treatment for small renal tumors, it does come with its risks of morbidity, and minimally invasive image-guided percutaneous ablation is becoming a viable alternative to operative resection. So let us delve into the why, when, and how of renal thermal ablation. So we saw tumors less than 4 centimeters at T1A, and partial nephrectomy does remain the standard of care in these patients, with ablation indicated as a curative option in a select few patients. The benign masses grow at a rate of about 0.2 to 0.3 centimeter per year, while the malignant ones are not, too far different from that, and growth is not related to the initial tumor size. So we may just be over-treating our small renal masses, and this is why there is a need for something less invasive, or that can do away with some morbidity and long-term complication rates. So when do we really ablate? We have a host of guidelines and international recommendations made by the AUA, ESMO, and NCCN. To summarize all three of them, masses less than 3 centimeters is what we consider as an indication to do renal thermal ablation. And of course, those patients who are frail, have a high surgical risk, or with solitary kidneys and compromised renal functions are those that should receive the ablative therapy. To summarize, the patients who are frail, with high surgical risk, with solitary kidney, compromised renal function with an estimated GFR less than 60 ml per minute, hereditary RCCs, which includes the von Hippel-Lindau, hereditary papillary carcinoma, etc., and those with multiple bilateral or multifocal renal tumors. These would be the typical candidates who would receive thermal ablation. How do we really ablate? So just to briefly go over our ablation protocol, we first, of course, do a good triphasic, that is a contrast-enhanced CT scan and MRI prior to the ablative therapy. We do a percutaneous biopsy for these patients. Certain specific population groups, like those who are diabetic with ileal loop diversions or ureteric stents in situ, are predisposed to getting certain infections in their urinary tract, and those would get some specific pre-medications. We optimize the bleeding parameters with a CPC coagulation profile and a good PAC fitness, because our renal radiofrequency ablation is done under general anesthesia. Using appropriate image guidance, typically CT scan in our setup, we would go ahead with an appropriate modality, that is either radiofrequency ablation, cryoablation, or MWA, that is microwave ablation. Just a very brief idea about renal mass biopsy. We biopsy all our patients prior to any ablative therapy, and you can do that either USG guided or CT guided. We use ultrasound guidance for most of our cases. Specific cases that are either in the upper pole or anterior cortex of the kidney, which are not amenable to USG guided sampling, are the ones that we target on CT scan. What we would like to highlight is biopsy prior to any or all interventions. As we saw in the first slide, that 20% of the small renal masses may turn out not to be malignant, and including fat-poor angiomyolipoma, oncocytomas. So, biopsy prior to any or all interventions, thermal ablation, SBRT, or even prior to starting active surveillance, we need proof. Prior to starting systemic therapy in metastatic cases, again, for further typing, as we discussed that, there are various types of RCCs with different tumor biologies. So we need a tissue diagnosis prior to starting therapy. and also certain cases where, an alternative etiology other than RCC might be at play. So if it's like an organized abscess or, an inflammatory pseudomass of the kidney, or, renal lymphoma, which we do see occasionally. And, in cases with a primary at some other site, it is wise to, perform a biopsy to rule out metastasis. For example, we do see some CA breast patients with enhancing renal masses that are SRMs and fit into that picture, but, later turn out to be metastasis and, require systemic therapy rather than local ablative therapy. Just some technical aspects to summarize. We use a coaxial biopsy cannula, and tumor seeding has not really been reported, so that's not a concern, and must not dissuade us from performing a percutaneous biopsy. Just a brief practical idea about post-biopsy care. Renal masses tend to bleed, and we use a host of post-embolization methods to help arrest this bleeding, right from autologous blood clot to the embolizing agent like gel foam, or occasionally even coils and glue. These are certain things we use to embolize a biopsy tract at the time of biopsy. If we see that there's significant bleeding, or expecting some post biopsy hematoma or bleeding. So moving on to the renal nephrometry score, which predicts the complexity of a renal mass and helps us decide whether partial or nephron sparing surgery is an option for the patient or not. To summarize this, with increasing renal nephrometry score, the surgical complexity of a renal mass increases, and the chances of a partial nephrectomy getting converted to a radical nephrectomy increase. So this would again help us to predict whether ablative therapy, is a viable alternative or not. Coming to the meat of this talk, which is tumor ablation, energy-based and chemical-based tumor ablation. Essentially, we're doing energy-based ablations now, which can be thermal or non-thermal. Thermal ablation, so either we use heat or we use cold. So if we're burning up the tumor, we're using either radiofrequency ablation, microwave, either we're using radiofrequency ablation or microwave ablation. And if we're sort of chilling up the tumor, we're using the cryoablation. We have the upcoming non-thermal ablation method, which is IRA, or irreversible electroporation. Just a brief idea about what we exactly do. So in radiofrequency ablation, we use radiofrequency electrodes and advance it to the target of interest. And with the help of alternating currents, it produces coagulative necrosis within that lesion. This is the most frequently used and most familiar tool at the interventional radiologist's disposal. And we can use either a multi-applicator technique, or we can use a single applicator technique. The second and most studied ablative method, more so abroad, is cryoablation, in which we, like we discussed, freeze the tumor. And cryoablation uses, our cryogenic gas media in order to cause ice ball formation within the lesion. This ice ball formation is very interesting, and it can be monitored intra-procedurally, allowing us control of the ablative zone and a more quantitative idea about the volume of tumor being ablated intra-procedurally. That is cryoablation. Next, we have the microwave ablation, which is similar to the radiofrequency ablation, but uses microwaves instead of the radiofrequency waves in order to produce tumor necrosis. The biggest advantage of the microwave ablation is it does not get affected with the presence of vasculature around a renal mass, and would result in a theoretically a more complete ablation. And then, of course, we have the up and coming modality of IRE, which has, of course, been studied more extensively for CA pancreas, but its applications are increasing and may be used in RCC as well in the future. We use certain adjuvant strategies practically in our setup to facilitate the ablation. These include hydro or pneumodissection, in which we use either any water media like dextrose solution or normal saline, depending on the type of ablation, and displace certain critical or vital structures in the vicinity of the tumor. These include either bowel loops or any neural structures around the lesion, or it can even include musculature around the renal mass. And we hydrodissect them or pneumodissect them away from the tumor to facilitate an ablation that is safe and complete. Second is lipiodol angioembolization. So renal masses on plain scan are not really that well appreciated. So to better delineate the lesion, we perform an angioembolization with an embolizing agent or lipiodol prior to the ablation. And then subsequently, we take these tumors for ablative therapy. The biggest risk that we have is of, in particularly cases that are close to the renal hilum, is of a ureteric injury, that the thermal ablation may, ablate some part of the renal pelvic lysis system and result in hydronephrosis or obstructive uropathy. And this we, use piloperfusion, that is, we do ureteric stenting of these patients, and interrupt procedurally constant irrigation is provided into the pelvic lysis system, allowing that to be safeguarded from the ablative zone. So we know that RFA may lead to 100% ablations in tumors that are smaller than 3 centimeter. And with every increase in size above that, we may have a risk of incomplete ablation or a need to have a second or subsequent ablation that may be needed in the subsequent sessions. How do we manage our patients post-procedurally? Immediate post-ablation, we, of course, have a hemodynamic monitoring system, and we do a post-ablation scan on table to confirm the technical success of the ablation. We do a follow-up contrast-enhanced imaging, typically with a triphasic CT, that is a renal protocol CT, and a dynamic CE MRI, that is contrast-enhanced MRI, at 4 to 6 weeks to assess the status. If there is a suspicion of subtotal treatment at this point, we would go ahead with another session of ablation. That is, we would re-ablate. If this treatment is considered definitive, that is, we've received an A0 ablation, to call it, we would follow that up with a contrast enhanced imaging. And, we may consider an intermediate risk protocol as per the NCCN. So that is repeat imaging every 3 to 6 months for 1 year. And this imaging we typically do with contrast enhanced MRI rather than CT, because most of our ablation patients are those who have, either solitary kidney or poor renal function. So we would rather subject them to a dynamic CE MRI. And occasionally we supplement that with contrast enhanced ultrasound, which uses a sonoview medium that is not nephrotoxic at all. Let's go through some cases. So first case is a 43-year-old male patient who had Hep C and, incidentally presented with a small renal mass.
Antariksh, I think we'll discuss the cases later. Let's move on. There will be multiple cases to discuss. You can give your comments there.
Yes, sir, sure.
Right.
So, Antariksh, you can just go to the final couple of slides and talk about the evidence. That should be fine. Yeah, you can skip this. Skip.
So just to summarize,
yeah, this should be okay. This will be the last slide. You can just talk about.
So, where do we stand with ablation? So ablation versus surgical techniques. Zing et al. Actually performed a survival outcome analysis from the SEER registry data in 10,000 odd patients. And with propensity score matching, they actually found no significant difference in the 9-year cancer-specific survival for thermal ablation compared to partial nephrectomy or radical nephrectomy. A comparison in the SEER registry data was also performed by Yulig et al., in which they found that in 770 odd patients of T1A RCC who were managed with either cryoablation or a heat-based thermal ablation, that is RF ablation or microwave, there was no significant difference in the cancer-specific survival comparing cryosurgery to the heat-based thermal ablation. And where do we stand with ablation versus active surveillance? So, of course, as one would expect, that the clinical T1A renal cancers that were either treated with local tumor ablation or observation, there was a higher mortality for active surveillance than local tumor ablation, as one would expect. So just to skip over some of these slides in view of time. And this one,
I think that's fine, Antariksh. We'll lack of time, we'll move on.
Okay, great. So
Thank you very much. Sorry to cut you off. Sanjay?
Any questions? Probably after you're done, we will ask for any questions.
There is one question specifically, Antariksh. While I load up, you can see it here. Can
you talk about ice ball fracture and when would you be worried about
sharing, Antariksh?
can you hear me, sir?
Stop sharing your screen.
Yeah, is that, yeah.
So let me take that question. I think the
Yeah.
ice ball fracture. So ice ball fracture normally happens when we try to withdraw the ice probe, the cryo probe that we introduced, when it is still hard to pull. So whenever without the ice ball becoming soft, if we attempt to pull the cryo probe out, that is when it results in an ice ball fracture. So there is a definitive way how it has to be removed. We have to wait for a couple of minutes, and that is called thawing. So once a bit around the cryo probe there is some thawing, then the probe will come out very easily. And in our experience, we have not faced any um, ice ball fracture. So that's not a concern in today's date.
Antariksh, can you please stop sharing your screen? And while I load my talk, one common thing I always wondered, and most of my residents as I would. So Nitin, how do you choose each of these? I mean, is it
That's what I was
availability,
going to
in
ask.
size?
Correct. So, like you answered yourself, one is the availability of the machine. So, RFA has been in India for more than in the globally for the last 3 decades, and in India for at least the last 2 decades. And everybody are very conversant and familiar with using the RFA machine. On the other hand, cryo is a very new entrant. It has just been even with us at Tata Hospital for the last couple of years. But globally, for renal masses, we are moving away from heat-based, that is RFA and microwave, to cryo-based for the simple reason that one cryoablation does not require general anesthesia. And second, most importantly, it can be, we can see the ice ball, be it in ultrasound or be it in CT scan, we can see the ice ball and accordingly tailor the ablation zone. So we can, when it is going too close to the pelvis or some other critical structures, we can stop the ablation in that particular area so that the tumor itself is ablated properly. And third, as compared to RFA, the other benefit is it's resistant to pelvic ileal system. So the damage to pelvic ileal system is not there when in cryoablation as compared to RFA.
So if you have all three,
Cryo.
you would prefer cryo as a
Yes.
clearly. Is it more expensive for the patient?
Yes. So the RFA electrode on it costs around 75,000, but the cryo probe is around 1 lakh. So it is expensive in that part, but the hospital stay, the need for GA, the post ablation complications is much less.
Thank you so much.
I just want to ask one question. Do you do
Yes, please.
freeze thaw more than once, or is it just only once you freeze it, and then once you have thawed it, you take out the probe?
No. Everything has got a fixed protocol. So depending upon which company, the cryo equipment we are using, the size of the cryo probe, the ablation zone that we get, it can be one, or the beauty of ablation is that you can have an overlapping ablation. So you ablate, then you find that some area is not covered. So you can just freeze it for a longer time till that particular zone is completed. So the freeze thaw, freeze cycle, it can be repeated as per the requirement, as per the size of the tumor.
Okay, thank you, Nitin.
Yes. So please go ahead with your talk, sir.
I'll carry on, Sanjay.
Yeah, you can.
So we'll come to the other much less known and much less understood modality for exactly the same indications that we talked in the previous two talks. I don't think there is any difference in the indications. And again, I'll show that to you. That is radiotherapy. Now, this the talk is there are radiation oncology residents and urology residents here. So we ask ourselves, we'll try to answer these. Is it safe? Is the local control good? I have a normal linear accelerator, run of the mill linear accelerator. Can I really pull it off? How many fractions should I give? And how should I do some of the technical stuff that I'll not talk about? But more importantly, for the urologists, they often wonder, patient doesn't want surgery, so why not do RFA? And what Antariksh has just told us, what is the advantage that radiotherapy is giving you that this can't? So we'll try to answer that. One kidney, large tumor, can we do it? And most importantly, even if you send a patient for radiotherapy, uh, although in TMH we follow them ourselves, but many of the time they will come back to the urologist and you must know how to manage the follow-up. So let's talk about some of these things. It's been drummed in radiation oncologists from the time we join our course that kidney cancer radiotherapy doesn't work. It's too resistant. And there's many reasons for that, because treatment was given like this in the 80s and 90s, large fields, and nobody knew what they were doing and giving a small dose. And of course, radiotherapy won't work. Since then, we have become very fancy, and you all know that. And we have come to realize that giving a very large dose per fraction, normally we give 1, 2 to 3 gray per fraction, but if we give 8 to 10 to 15 gray single dose, things happen differently at a cellular level. If you give single normal fraction, 80–90% of the RCCs cells are hypoxic, and that causes a problem that there's a normal tumor cell damage by direct cell death, and there is also a mechanism of microvascular dysfunction because of endothelial apoptosis that is blocked because of the hypoxia. But what the single fraction does, a very large dose per fraction, is it unblocks that mechanism, and then we get the tumor kill because of a certain different pathway. So that is what it overcomes the hypoxia in the cells. And so leveraging all our technology and this biology that I showed you, we have challenged the conventional wisdom and now saying that radiotherapy does work in RCCs. Let us see how it does. And what is the proof of this? About just last year, 1.5 years back, this very large, well, not, we saw 1,000, 5,000, 10,000 RFA data. All that was retrospective. I was just telling that to Nitin. Surprising, there is very little prospective data on any of that. This was in Lancet Oncology, 190 patients prospectively, 5 years of follow-up. These were relatively large tumors. The median size was 4.2 centimeters. A third of them were solitary kidneys. And this was the outcome. At 5 years, 92% patients had cancer-specific survival. Basically, at 5 years, 5% of them had a local failure. Not bad at all, considering anything that you have seen recently, especially the active surveillance component. And these are the same patients that would undergo surveillance because they cannot undergo a nephrectomy, or they cannot get or afford an RFA. Now, one big advantage that radiotherapy has as compared to the previous modalities is for larger tumors. And you can see here, and I'll show you more data. This is only T3B. Antariksh told you about T1A, which is less than 4 centimeters. These are only 9,500 patients. 1/3 of them had a single kidney. All of them were more than 4 centimeters. You can still see a very good local control and cancer-specific survival at 5 years. And that is the big advantage that SBRT or radiotherapy provides as compared to, one of the advantages as compared to thermal ablation. The solitary kidney is a very reasonably common thing we see in practice. Either they don't have a kidney, or they've had a nephrectomy previously, or some other pathology. I know even at the best hands, I have seen surgeons, uro-oncologists thinking twice, thinking 3 times whether they should go ahead with the NSS. And my suggestion, strong suggestion would be that, look, there is a very good option here. Again, single kidney, 5 years down, not even one patient required hemodialysis. So the GFR does go down, and I'll show that to you, but a great option of preserving some amount of renal function even after SBRT. Again, even thermal ablation can be done, but similar indications. I have shown you this. I mean, previously also we saw exactly the same lot of patients that we spoke about earlier. Now, the advantages are obviously we do not need to give any anesthetic. Perihilar tumors is now Nitin just said that perihilar is okay for cryoablation, but for RFA it's not okay. But for radiotherapy, there is absolutely no problem. Larger tumors, and believe me, by large, I mean even 8 centimeter tumors have been treated with SBRT. It can be treated. We don't do that very often, but there's plenty of literature that says that they can be treated safely. So even 4 centimeter, 5 centimeters, very often we see them. So that can be treated. And clearly it's non-invasive as compared to any of the other modalities. To assess response, there are two aspects to it. One is assessing the tumor response and assessing the renal function. Very important to understand as urologists or people following it up. It is very tempting to want to biopsy a tumor after radiotherapy. Don't do it. The response is quite slow and takes years, and you may find stable or the disease, the size of the tumor going up and down. So it is very slow. That is the first thing you must understand. Sometimes you can see a little up and down of the disease, but over the size, but over a period of time, it goes down. So it takes years. So that is one thing to understand. And it is clearly been documented that we must avoid biopsying because you cannot interpret those biopsies. In the Lancet paper that I showed you, the second aspect is what do you expect the kidney function to go? Obviously, if you irradiate, or even if you do a nephrectomy, or even if you do a RFA, the kidney function will go down. What is very well documented is the GFR in about 3 years falls by about 10 ml per minute. And in about 5 years, it goes down by about 13 ml per minute. So that is a buffer that we must keep. This is average. Some may go down less, some may go down more. So this is the buffer that you must keep in mind before. So obviously, if somebody has 2 kidneys, and then that's not a problem at all. This becomes important if it's a solitary kidney and the GFR is close to 30. Below that, I would be careful in taking it up, 28 to 30. Same indications. I'm not going to go through it, just what we discussed. Now, you may think that radiotherapy happens over many weeks, and that is what classically it happens. Very, very interesting stuff here. You can see this Lancet paper had 2 fractionation schemes. Some of the patients, about 109, were treated with multi-fraction, and this was 3 fractions actually. 42 gray was given in 3 fractions. 42 gray given in, this was 4 fractions, average 3 to 5. And there was another lot that was given 25 gray in 1 fraction. Okay. And very interestingly, the single fraction fellows seemed to do better. So maybe they were smaller, maybe there was something else happening there, maybe it is biology, but there's very interesting indication that if you can pull it off in a single fraction, the outcomes seem to be better. So we basically call the patient, do a planning CT scan, do the planning, call the patient back, 1 fraction, that's it. Now, some are amenable to single fraction, some are amenable to more than 1 fraction, and we'll discuss that in the next few minutes. You can see here a small tumor there. There's no other issues. This can go for a single fraction. That can have a single fraction. A much larger tumor that I would treat with more than a single fraction. You can see even that can be treated with SBRT. That's pretty large tumor. Clearly, you can't do any ablation for that. Now, very, very interesting. And I was just again telling Nitin this. Surprisingly, all the thermal ablations has zero prospective data. The lots of thousands of patients have been treated. This came out last week, 10 days back. This is called fast track. 70 patients were treated in a phase 2 prospective trial. This was published in Lancet Oncology. Median size was 4.5 centimeters. Median follow-up was 4 years. The local control is 100%, which is quite remarkable. This has all been done prospectively, and there were 2 events for distant metastasis, but you can see how effective the treatment is. Now, as radiation oncologists, we don't like a kidney and a little juicy fellow there and a little bowel there. We don't like it. I don't know if this is okay for RFA or cryo or any of these, or you also don't like bowel sitting there. Hydrodissect. So we would not treat this normally with SBRT, but I found this very recently on Twitter. Somebody from Australia had done this. They put in hyaluronic acid spacer between the bowel, and if Nitin and Antariksh can tell us how this can be done, it will be a great thing for that we can explore. If we can put in something, hydrodissect, put in some spacer that will stay there, we'll have to think about it.
Technique wise, it is not challenging. So you give us something that stays for 6 weeks. It can be.
Hyaluronate stays. So we should try that.
Yeah.
All right. Now, how is this better as you as urologists or uro-oncologists, when you have a patient, almost all of you work in centers that have got one of these machines. They are not fancy. I have not given them fancy names. They are just tools. And you can send them down to your friendly neighborhood radonc. And these are all standard stuff. This is not hi-fi stuff. You just need a modern linear accelerator with image guidance. I'm sure all of you have that in your hospitals. We have to deliver 40 to 50 gray in 3 to 5 fractions and reasonably good physics support. So I don't think it's a very difficult thing in a modern radiation oncology department. So that's my summary again. It can be done easily in a standard department. Don't biopsies, the responses are slow and steady and they keep falling over years, and the GFR drops by about 10 to 15 in 3 to 5 years. So that's what you have to take away from this stuff. Thank you so much.
But you also need a biopsy prior to starting.
Of course, we always need a biopsy prior to starting. And one of the things we often discuss in the JC is, for thermal ablation, do you do biopsies at this? You do same setting? Is that how it works? So you do biopsy and frozen? Is that what you do?
So what we do is that we have got a on-site cytologist. So we just sample, ask them whether it is
cancer
adequate
or not.
Yes. So they tell it within a minute.
Right.
Then we go ahead and ablate it. So we take course, which can be reported later on, but adequacy is tested.
Thank you so much. Sanjay?
Yeah, we can go on to the rapid fire
Yeah, all right.
clinical scenarios.
So moving on to case discussion based on theory, what we learned just now. So this is 60-year-old male, known hypertensive, diabetes, and chronic kidney disease. Incidentally detected 3.5 centimeter right renal mass, which is abutting the hilum and the vasculature. The estimated GFR is 35 ml per minute, biopsy proven renal cell carcinoma. I would like to ask Dr. Sugam if he is here. How will you discuss the treatment options with this patient? He has come to surgical oncology OPD.
Am I audible, sir?
Yeah, you are audible.
Yes.
So the treatment option of this patient includes a partial nephrectomy, that is NSS, and other ablative therapies that we have discussed. It is not an absolute some contraindication for partial nephrectomy, just that the tumor is abutting the renal hilum and close to the vasculature. So the complications that we normally explain to the patient in post-operative period, such as that of the leaks or post-op fistulas, they are slightly higher when the tumor is complex. But in an experience center where these tumors are being done routinely, partial nephrectomy is feasible option in this case. If the patient is refusing surgery, or if in this case he is having hypertension, diabetes, CKD, not willing for surgery, or is a high risk candidate for surgery, then he may go for ablative options that we have discussed.
Thank you. Dr. Antariksh, can you opine about the treatment options if patient comes to you?
So I think like Dr. Sugam has said that given the patient has a lot of comorbidities, particularly a low EGFR, I think this would make for a great candidate for performing cryoablation because we can monitor the ablation zone real time with the ice ball formation as well. So that would ensure that we've got a complete ablation or an A0 ablation on table. And technique wise, this is not in a challenging location for us to access. Probably we would just hydrodissect the psoas muscle, and like because it has a neural supply there.
So proximity to the renal vasculature or hilum is not very challenging for the RFA or the cryoablation.
So proximity, I mean, the thing is, so yeah, I mean, it can sometimes, to say that we don't ablate in central lesions would be, not a correct thing at all because we ablate, even when, the RCC or a small renal mass is close to the renal hilum. We have adjuvant techniques that help us, maintain the piloperfusion, etc. So this lesion will not be a problem for us to ablate. We should be able to do it.
Can you give us an estimate of approximately how many centers in India have cryoablation? Is it in hundreds? Is it in tens? Is it in thousands?
I
And
would probably on the side of hundreds, tens rather, not hundreds at all.
so it's not widely available. Is that about right? But RFA is widely available.
RFA would be in 50s and all, but cryo would be in single digit.
Single digit. So let us assume we have to do RFA here and you're okay. There's no problem with RFA.
So RFA in this case, we would do a brief, like an intra-procedure or a pre-procedural ureteric stenting, for which of course we bother our urology colleagues and they put a ureteric stent which has constant irrigation in situ. And with the irrigation in situ with warm dextrose for RFA, we would go ahead with the ablation for such a
all right. Carry on, Manish.
And why do we do that, Antariksh? Why do we put an ureteric stent? Are we worried about strictures?
Right. So we're worried about, some of that heat being transmitted
So
to the.
Antariksh, just to correct, I would not say it's stent. It is ureteral catheter. So that is only for irrigation. So during the procedure, it is just on the day of the procedure, it's inserted into the ureter, of whichever side we are treating. And the warm saline is just, or the cold saline in this case is perfused if we are doing an RFA. And at the end of the procedure, it is removed. So this is just to prevent any damage to the ureter. So stent per se is not put inside.
And that's removed immediately after
Yes,
the
after the
procedure.
procedure.
Carry on.
Dr. Manish, do you think there are any challenges to treat this patient with SBRT?
No. This patient is ideally suited, in my opinion, for SBRT. He has multiple comorbs, not fit or inoperable, or has refused for surgery, has a lesion 3.5 cm, in excess of 3 cm, sitting close to the hilum. So this is a patient in which, and has a EGFR of 35, which, as sir said, 20, over and above 28 to 30, we are comfortable. So this is a patient whom I will be happy to offer SBRT to.
Okay. Can I just back for active surveillance? We can keep an eye on it as well, isn't it? It's 3.5 centimeters, under 4 centimeters in a chronic renal failure patient.
So that is the thing I was saying. If he lives for 5 years, the chance that his disease is controlled or he will be alive. Well, cancer specific survival is the same, isn't it? Yeah. Sure.
Yes.
Okay.
I just had a question, sorry, Dr. Manish. So what about the doses to the renal pelvis actually? So like.
Yes. So unlike ablation, the pelvic calacial system is not an OAR for us so far. And with SBRT, so the image when we talk about radiotherapy is not of two beams colluding and creating a huge dose wash. So the image with SBRT, what I want viewers to have is a very, very conformal, tight dose distribution. And so we can actually conform the doses very conformally to the lesion itself. The 50% or the intermediate dose wash, we can restrict very nicely without horns. So the pelvic calacial system in SBRT is not an organ at risk, so to say.
For example, there is a small vessel just abutting the tumor as well. So even that would not be at risk, like for vascular injury.
No, no.
Thank God that the vessels are not organs at risk. We would have been
Yeah.
out of a job, man. Nowhere in the body. Vessels somehow tolerate everything we give them.
Yes, yes, sir.
So moving on to next case. So this is 66-year-old male with uncontrolled diabetes mellitus CKD and history of CVA on anticoagulants, evaluated for renal stone and found to have incidental left renal mass, and right kidney is atrophic, non-functional. On DTPA, the left kidney function GFR is 29 ml per minute. Again, I would like to ask all the panelists what would be the treatment options in this case when patient has only one single functional kidney. Antariksh, can you start?
Right. So again, location wise and with
And
risk.
please, guys, you are not bound to say that we will follow our own things. You are free to
Yeah.
choose anything else.
Right. Okay. Even having heard that, sir, but for such a case with, a single functioning kidney with poor function, actually, ablation is a modality that, we can consider. So I would consider thermal ablation in this case, and it should be fairly easy to perform. Except the aspirin. So again, we would just withhold the aspirin perhaps for 5 to 7 days with cardiology fitness from their side. And if that is okay, then we can go ahead with an ablation. If that is not all right and that becomes a deal breaker, then yeah, maybe SBRT if it has a role here, then that can be considered, I suppose.
So as we can see that renal function is already compromised. So what would be the ideal imaging modality follow-up and for response assessment in this case?
Right. So in such cases, typically, given that her her EGFR is so poor, we can do a CEUS for follow-up imaging, which should, completely suffice. And in such patients, he's already 66 years old. Even a CE MRI may be considered. But if you want to err on the side of caution, a CEUS should be fine to check for post-ablation response.
Okay, thank you.
Again, this
Thank-
patient is, we can offer SBRT to this patient. Both the options are good, in my opinion, although the GFR is still borderline, but I would want sir's word also on this because this patient also has multiple comorbs. I think both the options are okay.
Here, I would err on the side of actually surveillance if that is.
Surveillance. It's a very
Yeah,
small
because
lesion.
Yeah,
we don't
size is
really
2 cm.
need to wield
cm.
our tools where we don't need to. I think we have to have that balance. Just because we can cut, ablate, or burn, or thaw, or whatever else, we can probably leave this man alone. I would think.
Can I,
Yes.
Vedang, there are a couple of questions. If you can, there are now 3 questions. If you can answer them, they're technical radiotherapy
I will
ones.
do. I'll do.
Yeah. So moving on to third case.
Sorry. Okay. Yeah, you can go
Oh.
on until Vedang gets hang of the
Okay.
questions. Go ahead.
So he's 52-year-old male, newly diagnosed hypertensive, evaluated for hematuria. CT scan suggestive bilateral renal mass. We can see the large left renal mass completely involving the left kidney. And there are 2 renal masses which can be seen in the right kidney. So this patient underwent left radical nephrectomy for this left renal mass. And now the question is, what would be the management of right renal mass, which are multiple in number? It was further evaluated with the MRI, and on MRI we can see at least 6 irregular heterogeneous partly exophytic lesions in the right kidney. Size of the largest lesion is 2.2 by 1.4 centimeter. and the renal function of right kidney is GFR is 35 ml per minute. So what would be the management options for this patient?
So I think
Dr. Sugam?
The patient has multiple tumors on the right side. So I think it will be technically a bit challenging to remove all the tumors. I feel that patient should be given all the options. He should be clearly told about all the available options, their complications, and the patient should decide the treatment modality.
Okay. Dr. Antariksh, do you need
Can I
her to
just
add
ask,
anything?
if we were giving SBRT, can you put the radiotherapy on multi-targets at the same time, or is it you can only target one at a time? And same for cryotherapy as well. Probably you can only do one at a time, isn't it?
Sir, would you like to comment on this?
You guys can, Manish.
So if
Dr. Manish?
both the lesions are contiguous, then we can probably, but the distance matters between the two lesions because SBRT employs higher dose per fraction. We don't want a largish volume, largish intervening normal parenchyma. We don't want that. So
Technically, it is possible, Sanjay. It would really depend on, especially if it is a single kidney, then I would avoid it. If it is both kidneys and one of them has two wherever, then that is quite possible.
Okay.
And Nitin has something to add.
So this is again a very unusual situation wherein
Yes.
6 lesions are there. Here I feel there will be some constraint for the radiation side because the lesions are small and multiple in location, and by the time you contrast plan, it necessarily all the 6 of them did not match. But in this case, what the technique Antariksh mentioned comes in handy. You do a lipidol angiography. So all those RCCs, they would actually light up with the lipidol, which can very easily be targeted. So once lipidol is put, I think the work becomes easy both, be it for the ablation or be it for SBRT. The tumor is highlighted. So then the choice is, how safely we can preserve the intervening parenchyma. And among the modality that are available, I think even Vedant sir also would agree that the amount of the decline in the GFR is least for the ablation. So surgery after that, to some extent, SBRT also has got less reduction, but the least would be for the intervention modality, especially cryo. So in this particular patient, if 6 and intervening parenchyma or scattered apart, then I think it would slightly favor ablation. What do you think, sir?
Right.
So do we need to treat all these 6 lesions?
Yes, again, coming to that question, we are back to active surveillance. What we would essentially do is that the largest one and the fastest growing one in the serial surveillance scan, we would like to treat.
Okay.
This patient requires genetic testing. It is a bilateral multifocal renal tumors. Looks like some syndromic. So based on the genetic testing, and there's something called rule of 3 during the surveillance of multifocal renal masses. So we can apply that and observe. So usually in multifocal and syndromic hereditary renal masses grow very slowly. So we can definitely keep this patient under surveillance.
So the rule of 3 would be that you would wait until one of the lesions crosses the 3 centimeters, but when you go in, you would take out all the lesions and reset the clock. You won't take out only the lesion that is more than 3 centimeters.
Okay.
More.
Yeah. Okay.
So
and
case number 4 is already discussed in Dr. Vedant sir's slide, that proximity to the critical structure. Like in this case, bowel loop is near to the left renal mass. So is it contraindication to any of the ablative therapy?
They will say they will do hydrodissection or hyaluronic acid.
It's already covered, so I'll skip this.
We can't do a mastectomy in this case. We would definitely do it for sure.
Okay.
if we cannot put a spacer, then we can even give 3 fractions. If we can plan for 3 to 5 fractions also.
Still too tight. Manish.
Still,
Okay. Thank you very much, team.
Yeah.
It's just that we are already 10 minutes above.
Yeah.
Veda, do you want to summarize and then we'll close?
We carry on. Please, you can summarize. There's a question
Okay,
about the
you
dose constraints to the uninvolved kidney. So, Dr. Madhuri, very, very little dose goes to the uninvolved. You mean contralateral or the uninvolved? That is.
ipsilateral, but uninvolved without the tumor, isn't it?
So we have to make sure that this dose spillage is out of the kidney and not going into the uninvolved kidney. So that our dose distribution arcs would be based on that. Parth Verma, we have not had any issues with bowel ever. Because generally we are careful with that. So we would not exceed constraints. So
And does the pathology, sorry, there were other questions for other people.
So I have answered those. Pathology for radiotherapy, I don't know, but I don't think it matters because the dose that we are giving. So in TMH, what we've been doing for the last 5-6 years, we've done about 30-35 cases, is we do 45 gray in 3 fractions or 21 gray in 1 fraction if we can. So that's nothing. I mean, just 3 days of treatment.
Okay. Thank you very much, everyone, for your involvement with this. It's a bit of an unusual one, but it's something that is going to be discussed more and more. Starting off with the active surveillance, it is I think that we always say active surveillance stroke watchful wait in India, at least, especially because we are not very sure what we are actually trying to do. In those sort of patients, active surveillance seems to be a reasonable option because not many of them metastasize. And when you look at the cancer-specific outcome, they seem to be the same. The other options, radiofrequency, cryo, or SBRT. The reason why SBRT, I think, will be a bit more ahead in the near future is just because majority of the radiation oncology departments in the country do have the equipment. They just need to improve their expertise in delivering this. So rather than any of the consumables that are required for either cryoablation or radiofrequency ablation.
That's correct. Yeah.
So if you were looking for India's specific minimal invasive treatment, I think SBRT will have a role in the near future.
Thank you. I just had one question because we are talking of India and we are talking active surveillance. We don't encourage it in prostate. We don't encourage it in testis. We don't encourage it anywhere else. Why do we encourage it in kidney?
Just because, okay, we don't have any India-specific data, that's the baseline. But what I meant was we are not very sure whether we are saying active surveillance or watchful wait. Whereas in prostate, we know where we are using the word active surveillance and where we are using the word watchful wait. So in India, it's always stroke watchful wait. And these are elderly patients whom you know you will end up with complications. So you're just waiting for them to show themselves up. Either the tumor is growing or they become symptomatic, in which case you go and intervene.
Okay, I think we can stop there. Thank you, everybody. Thank you, Sanjay. Thank you.
Thank you. Thanks for your efforts.
Raghunath. Thank you. Bye.
Thank you.
Thank you.